This episode is brought to you by Pacifico. When having a Pacifico beer with friends you just met turns into hitting up their friend's local art show, getting inspired to create something together,
look.
and painting your first mural, you found what was waiting for you. Pacifico. Life's waiting. 21 plus only. Discover responsibly. Pacifico Clara Beer. Imported by Crown Import, Chicago, Illinois.
Welcome to the New Chemist podcast.
Bienvenidos al podcast del nuevo químico.
Καλώς ήρθατε στο podcast του New Chemist. Welkom bij de podcast van The New Chemist.
Bienvenue sur le podcast du nouveau chimiste. Bem-vindo ao podcast do novo químico.
Welcome to the New Chemist podcast. Work hard. Be value-driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here, rooting and cheering for you. Don't give up.
Travaillez dur. Soyez axés sur la valeur. Tu peux le faire. Vous pouvez grandir et l'apprendre. Vous pouvez être la différence dont vous et votre communauté avez besoin. N'abandonnez pas. Nous sommes ici pour vous encourager et vous encourager. N'abandonnez pas. Trabalhar duro. Seja orientado por valores. Você consegue. Você pode crescer e aprender. Você pode ser a diferença que você e sua comunidade precisam. Não desista. Estamos aqui torcendo e torcendo por você. Não desista.
Δούλεψε σκληρά. Να οδηγείτε στην αξία. Μπορείς να το κάνεις. Μπορείτε να μεγαλώσετε και να το μάθετε. Μπορείτε να είστε η διαφορά που χρειάζεστε εσείς και η κοινότητά σας. Μην τα παρατάς. Είμαστε εδώ για να σας ζητοκραυγάσουμε. Μην τα παρατάς.
Trabaja duro. Sea impulsado por el valor. Puedes hacerlo. Puedes crecer y aprenderlo. Usted puede ser la diferencia que usted y su comunidad necesitan. No te rindas, estamos aquí animándote y animándote. No te rindas.
Werk hard. Wees waardegedreven. Je kunt het. Je kunt groeien en leren. U kunt het verschil zijn dat u en uw gemeenschap nodig hebben. Geef niet op. We zijn hier om voor je te roten en te juichen. Geef niet op.
Work hard. Be value-driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here rooting and cheering for you. Don't give up. Thanks for listening. We're glad you were able to tune into this podcast. Once again, this is the new Chemist, where we discuss chemistry, which simply put is the science of change, as well as the other sciences, careers, community, research, and COVID-19. Thanks again for listening. Note, the views on this podcast represent those of my guest and I. Okay, this is another addendum to the episodes entitled The Journey to NAPLEX Success. This is another addendum. We're going to be talking about agonists and antagonists and all the different flavors. So agonists are drugs that bind to a cell's receptor in order to mimic the effect of a substance the body naturally produces that binds to the same receptor. Two main classes of receptor ligands in pharmacology. You have agonists and antagonists, and the references for this episode will be listed in the episode description. So agonists tend to be smaller molecules that affect the activation of receptors. Note, this may result in stimulation or inhibition of the cell and organ function. Full agonists produce maximal biological response. Full agonists produce maximal biological response. Has maximal positive intrinsic activity, aka efficacy. Partial agonists, whereas partial agonists produce partial maximal biological response as compared to full agonists. So partial agonists produce partial maximal biological response. Partial agonists have lower positive intrinsic activity, and they may competitively inhibit full agonists, preventing maximal biological response. So let's run through that again. Full agonists produce maximal biological response. It has maximal positive intrinsic activity, so efficacy. And partial agonists produce partial maximal biological response as compared to full agonists. They have lower positive intrinsic activity, and they may competitively inhibit full agonists, preventing maximal biological response. If the partial agonist is bound to a receptor, the full agonist typically cannot bind. Why use a partial agonist? Full agonists may cause too much activation, resulting in toxicity or receptor adaptation or prolonged use, like desensitization and downregulation. The lower efficacy of partial agonists minimizes these complications. Now you also have inverse agonists. These produce opposite biological response to that of the endogenous agonist. Has negative intrinsic activity. Okay. So let's talk about antagonists. Antagonists tend to be larger molecules producing inhibitory effects. An inhibitory effect. There are antagonists that act at the receptor, also known as receptor antagonists. So let's make sure we keep this thing in focus. So antagonists, by definition, have zero intrinsic activity. Antagonists, by definition, have zero intrinsic activity. Full agonists have intrinsic activity of 100%. Maximum biological response. Partial agonists have intrinsic activity greater than 0 but less than 100. And partial agonists can competitively inhibit a full agonist. You also have inverse agonists, so you have intrinsic activity less than 0. And then you also have non-competitive antagonists, and those can be unsurmountable, depending on them being irreversible, allosteric. You will get to that. So let's keep going. Just a quick note: efficacy is referring to different levels of biological response or intracellular signaling when they occupy the same receptor.
Intrinsic activity refers to the maximal possible effect that can be produced by a drug. Intrinsic activity is determined by the drug-receptor relationship for a drug that acts on the receptor. Okay, you also have efficacy. Efficacy, you also have affinity, which is the measure of the ability of the drug to bind to its molecular target. So the affinity is a measure of the ability of the drug to bind to its molecular target. The VC50, which is a measure of the potency of the drug. So let's keep going. Antagonists. They tend to be larger molecules exhibiting inhibitory effects. There are antagonists that act the receptor. These are known as receptor antagonists. Antagonists do not have intrinsic activity. They simply block the agonists from binding. So if we think about these things on a spectrum, we think about efficacy related to the endogenous ligand, you have your full inverse agonist at less than 0, your partial inverse agonist still less than 0, you have your antagonist at 0, and you have your partial agonist, which is greater than 0 and less than 100. We're talking about intrinsic activity. And then you have your full agonist at 100%. Okay. Intrinsic activity, positive intrinsic activity. So competitive antagonists, reversible or surmountable, binds to a receptor at the same site as the endogenous or pharmacological agonist, blocking agonist binding and therefore receptor activation. So it binds to a receptor at the same site as an endogenous or pharmacological agonist, blocking agonist binding and therefore receptor activation. Okay, so if you were to look at the plot of an agonist versus agonist effect, when you include the competitive antagonist, it shifts to the right. These are ideal scenarios, of course. Okay, antagonism can be reversed by increasing the amount or dose of agonists. Thus, we have the surmountability. This is talking about competitive antagonists. So competitive antagonists do not affect agonist efficacy. They do decrease affinity and potency. So competitive antagonists do not affect agonist efficacy. They do decrease affinity and potency. Competitive antagonists have affinity or potency for the receptor, but not intrinsic activity. By definition, an antagonist does not have intrinsic activity. Receptors can interact with agonists or the competitive antagonists. Okay. And that is exclusive. Okay, non-competitive receptor antagonists. Non-competitive receptor antagonists. Non-competitive receptor antagonists, unsurmountable. So irreversible, binds to the same site as the agonist, not easily displaced, generally irreversible due to the covalent bonds between the antagonist and the receptor, reducing the number of receptors available to the agonist. So just a quick aside, picture a graph of an agonist versus a biological response with your minimum toxic concentration, referenced and noted, and your minimum effective concentration, referenced and noted. So let's just think about that. Think about that. And you have your MEC below and your MTC above. So MTC, minimum toxic concentration, minimum effective concentration. This is just picture this graph with these points noted on it. Okay. So with the full agonist and partial agonist starting at the same XY point, ideally, the partial agonist will plateau between the MTC and MEC. The minimum toxic concentration and minimum effective concentration, whereas the full agonist will have a higher biological response and plateau higher. Okay, let's keep going. In the absence of stereoreceptors, the dose response curve will show lower maximum when the agonist is combined with a non-competitive antagonist. However, in the presence of stereoreceptors, there's gradually or gradated upon increasing non-competitive antagonists, a decrease in agonist effect. So, however, in the presence of stereoreceptors, that is gradually or gradated upon increasing non-competitive antagonists, a decrease in agonist effect. So, allosteric non-competitive antagonists. So, allosteric is referring to the other side, and orthosterics is referring to the right binding site. So binding to the allosteric site modifies the conformation of the primary site, with negative allosteric antagonists resulting in an altered conformation that's less responsive to the agonist. So let's wrap this up. Physiological antagonists, molecules that do not bind the same receptor and as the endogenous ligand, but produce an effect opposite to the agonist effect. Molecules that do not bind the same receptor of the endogenous ligand, but produce an effect opposite to the agonist effect. So this is a physiological antagonist. Now a chemical antagonist, as we conclude, drugs do not interact with agonist receptor, but rather reduce the concentration of the agonist by forming a chemical complex. Let's go through that again. Physiological antagonists, molecules that do not bind the same receptor of the endogenous ligand, but produce an effect opposite to the agonist effect. Chemical antagonists, drugs do not interact with agonist receptor, but rather reduce the concentration of an agonist by forming a chemical complex. So hopefully this helped. These are important terms. It's important to know these things. These are like, in a way, these are very important. Very, very important. So all the best. Take care. This is the conclusion of this addendum. Okay, welcome to the New Chemist Podcast, episode 3C. We go back to the basics and discuss fundamental ideas that support an understanding of pharmacy ideas. And we're using the format of a telephone conversation. This is definitely an episode worth listening to. So it's important to note that the purpose of these episodes are not at all medical advice, medical suggestions, or medical counsel. These are aimed to provide support for pharmacists in training in educational and intellectually stimulating ways. Again, please note that these are not at all medical advice, medical suggestions, or medical counsel. Please see your local state and board certified physician, physician assistant, or nurse practitioner, and pharmacist for medical advice and suggestions. Once again, these are not at all for medical advice, suggestions, or counsel. Please see your local state and board certified physician, physician assistant, or nurse practitioner, and pharmacist for medical advice, suggestions, and counsel. The views in this podcast represent those of my guests and I. So, pharmacy school is a blast. However, you must be very dedicated and maintain a good integration of your self-care regimen, as well as your personal affairs, as well as your academic responsibilities. So let's run through a few quick facts and then we'll conclude this episode for today. So pharmacokinetics, it's what the body does to the drug. We're talking about absorption, distribution, metabolism, and excretion over time. What's the goal of pharmacokinetics? We want to control the amount of drug exposure. So let's talk about respiratory alkalosis. It involves a rise in blood pH due to hyperventilation, so that's excessive breathing, and a resulting decrease in carbon dioxide. Let's talk about acidosis. What is it? Blood pH lower than 7.35. So let's also talk about extravascular drug absorption. That involves oral, stomach, absorbing the intestine, metabolizing the liver. Some amount of drug reaches the systemic circulation, and the rest of the drug is excreted. Let's talk about intravascular drug absorption. Actually, we'll come back to that. Let's talk about the first pass effect. The initial metabolism in the liver of a drug absorbed from the gastrointestinal tract before the drug reaches systemic circulation through the bloodstream. Let's say that again. First pass effect. The initial metabolism in the liver of a drug absorbed from the gastrointestinal tract before the drug reaches systemic circulation through the bloodstream. Let's also talk about enterohepatic cycling. Drugs are transported through the bile back to the intestine, where they can be reabsorbed in the intestines, increasing the duration of action. One more time. Enterohepatic recycling. drugs are transported through the bile back to the intestine, where they can be reabsorbed in the intestines, increasing the duration of action. So when we administer intravenously, you have 100% bioavailability. Intravascular administration involves IV as well as intraarterial. Local activity will involve things like general pulmonary, topical, ocular, intraocular. Systemic activity will involve things like oral, sublingual, buccal, intramuscular, subcutaneous. Selective beta blockers. So we're just running through a litany of facts that are useful. It's primarily under the umbrella of pharmacy basics. So just running through some ideas quickly. Just to give people a quick refresher for those who are in training this time. Selective beta blockers, metoprolol, atenolol, all, bisoprolol, nebivolol, acebutolol, betaxolol, esmolol. How is drug absorbed? Active transport with transport proteins or passive diffusion. So we already mentioned how intravascular administration involves intravenous and intraarterial. Let's see what else can we talk about. So let's talk about dissolution. It's the process of drugs dissolving in the GI tract. Dissolution rate, we look at the Noyes-Whitney equation. Smaller the particle size, the greater the absorption. Increasing the surface area increases the drug absorption. Let's make a quick note of that. Dissolution rate, we look at the Noyes-Whitney equation. Smaller the particle size, the greater the absorption. Increasing the surface area increases the drug absorption. Almost rhymes. Now, how to limit drug degradation? You have your enteric coating, biodegradable polymers, so a acidic environment in the stomach won't destroy the drug, increasing the amount of drug absorption. Bioavailability. Bioavailability. Amount of drug available systemically to produce an effect. So how much of the drug is available in the drug to produce a therapeutic effect? So how much is available to produce a therapeutic effect? So formula percent of drug absorbed. The amount appears in systemic circulation or the amount administered. High bioavailability is above 70%. Low bioavailability is below 10%. Let's go back to that again. Formula percent of drug absorbed. Amount appears in systemic circulation over the amount administered. So amount appears in systemic circulation over the amount administered. High bioavailability is above 70%, whereas low bioavailability is below 10%. So let's see. Let's give an example. So if we have if we administered 100 milligrams of a drug orally, and 20 milligrams appears in systemic circulation, 20 over 100 is the same thing as 0.2. Multiply by 100 when we're talking about percent, it gives us 20%. Okay. And from the framework that we just discussed, that will give you an idea as to what extent or what amount of bioavailability is occurring with that problem. So drugs with 100% oral bioavailability, levofloxacin, linezolid. So those are examples of two. So formula for bioavailability, area under the plasma, concentration time curve, representing total drug exposure. That's a mouthful. Let's go over that again. Formula for bioavailability, area under the plasma, concentration time curve, representing total drug exposure. Okay, there are formulas for that. We can discuss that later. So what are the physicochemical properties that affect drug distribution? Lipophilicity. Lipids can easily cross the membrane. All the things that affect this drug distribution: molecular weight, ionization status. The charged particles cannot pass, non-charged particles can pass, and protein binding. So lipophilicity, molecular weight, ionization status, and protein binding. So LIMP, L-I-M-P, lipophilicity, ionization status, molecular weight, protein binding. Those are the lens to which you look at, or basically the parameters that you kind of look at when you're trying to determine understand what's affecting drug distribution. Also, let's go back to the formula for bioavailability. 100 times AUC subscript EX over AUC subscript IV times dose subscript IV over dose EX. So it's important to note that EX is referring to extravascular, IV is referring to intravenous, AUC is referring to area under the curve. 100 is being used because we're talking about percent, and F is absolute bioavailability. Let's run that back one more time. F is absolute bioavailability. We multiply by 100 because we're talking about percent. AUC is area under the curve. IV is referring to intravenous. EX is referring to extravascular. So F is 100 times AUC EX over AUC IV. And that whole thing is multiplied by dose IV over dose EX. So high protein binding. Drug has high affinity for albumin, so the amount of free drug will be low. The albumin acts as a reservoir for the drug, and it releases the free drug in small amounts to the tissue to exert its effect. This increases the duration of action. High protein binding. Drug has a high affinity for albumin, so the amount of free drug will be low. The albumin acts as a reservoir for the drug, and it releases the free drug in small amounts to the tissue to exert its effect. This increases the duration of action. 28. Albumin. So protein in the blood that's made in the liver. So let's see. Let's keep going. When a correction form, site-specific drug delivery. Antibodies bind to particular receptors on specific tissues or organs. Site-specific drug delivery involves antibodies binding to particular receptors on specific tissues or organs. So when are correction formulas needed? Highly bound protein drugs with patients whose serum albumin is low. Examples of highly protein bound drugs: phenytoin, warfarin. Examples of those. Let's look and see. What else can we talk about? Calcium corrected formula. So calcium, in brackets, reported serum plus, in brackets, 4.0, subtracting the albumin amount, and that difference is multiplied by 0.8. Phenytoin corrected formula. Total phenytoin measured over, in brackets, 0.2 times the albumin amount plus 0.1. So the product of 0.2 times the albumin amount in the bracket added to 0.1. The whole thing is a denominator under the numerator, which is total phenytoin measured. So volume of distribution. This is the amount of drug in body over plasma drug concentration. Okay, so small volume of distribution involves it being confined to plasma or extracellular space. Example of tobramycin, 0.2 liters per kilogram. Large volume distribution, wide distribution to all body tissues, so the plasma drug concentration is low. Anticycline is an example of that, 7 to 9 liters per kilogram. So guys, what kind of volume of distribution would you want a drug to have if you were treating a systemic infection? You can think about that, process that in your healthcare profession class or science class. Okay. Let's see what else to talk about. So metabolism involves the process by which a drug is converted from its original chemical structure to other chemical forms. The original chemical form is the parent drug. Other chemical forms, metabolites, occurs primarily in gut and liver. You want the drug to be lipophilic so it can cross the phospholipid bilayer and exert its effects on the tissues. The body undergoes multiple biological reactions to make these intermediates hydrophilic so that they can be excreted by the body. Okay, so lidocaine undergoes extensive first-pass metabolism in the liver, so it's only typically administered in the intravenous form. Okay. excretion, irreversible removal of the drug from the body. Organs for excretion, you have the kidneys, and that results. Kidneys function to produce urine. The gut, GI tract basically functions to produce feces. Lungs function to produce exhaled air. The skin functions to produce sweat. The liver functions to produce bile. So clearance is defined as the volume of plasma cleared of a drug over a period of time. Clearance is defined as the volume of plasma cleared of a drug over a period of time. Okay, two formulas for clearance involve the rate of elimination over concentration. Also, F times dose over area under the curve. Okay, so half-life, the time in which 50% of the drug is eliminated, T1/2. So first order elimination, constant percentage of drug is removed per unit time. The drug concentration is eliminated, and that's directly proportional to the concentration of the drug. Okay. Let's see what else we can talk about. Let's see. So, zero order elimination, the constant amount of drug is eliminated per unit time. So Michaelis-Menten kinetics, this is like, if you've done biochemistry and you're now in the pharmacy program, this is an idea that you see over and over and over again. So, let's think. Michaelis-Menten kinetics, you have your mixed order, your saturable or non-linear kinetics. Increasing the dose leads to a disproportionate increase in concentration. First section of the curve, lots of available enzymes. Second section, composition of enzymes, more drugs and binding sites available on enzyme. Third section, all the active sites on the enzymes are occupied. The drug is not being metabolized, leading to toxicity. So let's keep going. Km, concentration at half max of Vmax. Michaelis-Menten drugs, phenytoin, theophylline, voriconazole. Okay, let's keep going. It's important to note that let's just talk about a quick case scenario. The patient has been using phenytoin 100 milligrams 3 times daily. So TID, the phenytoin level was drawn and found to be 8.8 micrograms per milliliter, reference range 10 to 20 micrograms per milliliter. The prescriber doubled the dose to 20 milligrams 3 times daily, so TID. The patient started to slur words, felt fatigue, and returned to the clinic. The level was repeated and found to be 23.7 micrograms per milliliter. Which of the following is accurate regarding the most likely reason for the change in phenytoin level? So, what we understand is phenytoin metabolism can become saturated at higher doses. Phenytoin metabolism can become saturated at higher doses. Saturation point. Let's keep going now. Saturation point. Adding more substrate will make no difference in the reaction rate. Good rule of thumb for phenytoin: if there is 7 micrograms per milliliter in the serum, adjust doses in small increments, no more than 30 to 50 milligrams at a time. So Ke is the elimination rate constant. Let's see. The loading dose. Use of a higher dose than what is usually used for treatment to allow the drug to reach the concentration that exerts the therapeutic effect. As we progress, one of these episodes, we'll spend some time talking about therapeutic effects and therapeutic indices, therapeutic windows. Okay, so let's keep going. We're going to talk about some pharmacology basics now. Pharmacology is the body of knowledge concerned with the actions of chemicals on biological systems. What is medical pharmacology? It involves the use of chemicals in prevention, diagnosis, and treatment of disease. What is toxicology? It is concerned with the undesirable effects of chemicals on biological systems. What is pharmacokinetics? It involves what the body does to the drug. You have your ADME, your absorption, your distribution, your metabolism, your excretion. What is pharmacodynamics? How I think about this is when I look at the word, D comes with 4 of the letters, M, A, and N. So it's what the drug does to the body, or drug does to the mind. That's how I see it. That's how I process this. So pharmacodynamics, what the drug does to the body. What is onset of action? Is how much of the drug comes into circulation to produce the effect, determined by the route of administration and drug dosage. When you increase the drug dosage, the concentration of drug in the body will also increase. So what is onset of action? Is how much of the drug comes into circulation to produce effect. The effect, determined by the route of administration and drug dosage. When you increase drug dosage, the concentration of drug in the body will also increase. So what is duration of action affected by, or what can be affected by? The drug dosage, or higher the dosage. It also can be affected by the rate of distribution, the rate of metabolism, and the rate of excretion. So MEC, minimum effective concentration. It's the amount of drug required to produce a therapeutic effect. So what is the duration of action? It's the time between the rise to the decline at minimum effective concentration for therapeutic effect. What is the MOA, the mechanism of drug action? Drugs cannot produce any action in the body, can act on enzymes, ion channels, upregulate or downregulate the system within the body. So there are some more things we want to talk about. Ligands, so they're signaling molecules, RA, receptor existing in the active state, RI, receptor existing in the inactive state. Depending on whether you read, some people refer to, like in biochemistry, is referred to, they use different letters to describe those things in undergrad biochemistry. But for now, in this phase, we'll talk about RA being a receptor existing in an active state, RI, receptor existing in an inactive state. So the external receptor site. Ligands bind outside plasma membrane and produces change inside the cell. These are elegantly displayed with receptor proteins on the phospholipid bilayer. So internal receptor site. Drugs go inside the cell, bind the receptor inside the cell, moves the nucleus to produce desired effect. So mechanisms of agonist-mediated activation. You have your ion channels, your GPCRs, wonderful class of receptors, just excellent. Wonderful family, if you will. Receptor tyrosine kinases, intracellular hormone receptors. So those are things you want to like focus in on. Ion channel, ligand, gated voltage, gated second messenger regulated. Ligand gated ion channel, drug binds the ion channel, activating it to open, sodium enters, triggering an action potential. Voltage gated ion channel, change in charge or potential between the inside of the cell and the outside of the cell, causing the channels to open to maintain internal homeostasis. Inside the cell, the charge is between negative 70 millivolts and negative 90 millivolts to open the gate to maintain internal homeostasis. Okay, let's go. Second messenger regulated. Various second messengers are regulated certain channels by opening and closing them. Some include calcium and cyclic AMP. Cyclic AMP can cause the activation of enzymes which trigger signal transduction pathways. So your GPCRs, your guanine protein coupled receptors, a signal receptor protein in the plasma membrane that responds to the binding of a signal molecule by activating a G protein, also called a G protein linked receptor. Your RTKs, receptor tyrosine kinases. Insulin binds to tyrosine kinase receptor. Tyrosine kinase receptor undergoes autophosphorylation. Insulin receptor is activated. Downstream cascade of signals. Final signal is to recruit glucose transporters, GLUT. Move from cytosol to plasma membrane and take these into tissues for utilization or storage. So let's talk about some amino acids for a bit. Just for a quick bit, we know some amino acids with hydroxyl groups are your serine, tyrosine, and threonine. So serine, if you go from the peptide backbone and walk down the R group, you have, so serine has the methionine spacer, and hydroxyl tyrosine has your methionine spacer, your benzyl ring, and then your hydroxyl, and threonine has a methine spacer, then a methyl group that comes off from that, and then a hydroxyl group. Okay, so kinase is the enzyme that causes phosphorylation. If you want to look up the spacers in terms of methionine, TH2 methine CH is what we're referring to. We say those spacers. That's kind of organic chemistry talk, or speak, if you will, for those who are organic chemistry majors or who study some organic chemistry. So let's talk about kinases, enzymes that cause phosphorylation. So intracellular hormone receptor, mostly steroids, enter the cell easily because they are lipids, bind to receptors inside the cell in the cytoplasm, get activated, move to the nucleus, cause DNA transcription, which leads to the formation of particular proteins. So affinity, the measure of tightness in which a drug binds to a receptor. What is intrinsic activity? So the ability of a drug to activate a receptor upon binding. An agonist is a drug that limits the action of the endogenous ligand. Primary agonist, drug binds to the same recognition site as the endogenous agonist. So I've heard of allosteric, but this was a new one for me. Orthosteric. Orthosteric site, the primary or the right binding site. Allosteric agonist binds to a different region of the receptor. So allosteric is referring to another. That's what that word means, literally. Antagonist, drugs that block or reduce the activity of an agonist. So antagonist blocks the agonist. Agonist. And these have affinity but no intrinsic activity. And remember, intrinsic activity is the ability of a drug to activate a receptor upon binding. Asymptotic interaction, competition with agonists for the same overlapping site. Asymptotic interaction, competition with agonists for the same or overlapping site. You got your physical antagonist. Physically interacts and nullifies the action of the drug. Example, charcoal, which is a good absorbent. It binds alkaloid to form a complex and will be excreted. The chemical antagonist, the drug forms compounds with other substances like calcium and magnesium. Example, tetracycline binds to calcium in milk and then will be eliminated. You have your physiological antagonist, a drug that counters the effects of another by binding to a different receptor and causing opposing effects. Drugs that produce an opposite action by binding to a different receptor. Example, adrenaline is a physiological antagonist to histamine because adrenaline causes bronchodilation and histamine causes bronchoconstriction. Pharmacological antagonists. The drug that binds to the receptor and produces no effect and shows no intrinsic activity. And remember, intrinsic activity is basically the ability of a drug to activate a receptor upon binding. Partial agonists. A drug that binds to a receptor and causes a response as less than that caused by a full agonist. You have your inverse agonists. In the stomach, histamine receptors are constitutively activated. They're activated without stimulus. So under normal conditions, they're operating at 20%. Inverse agonists inhibits these receptors, bringing them down to 0%. Non-competitive agonists, same binding site agonist, resembles chemically with agonists. You have a right shift on the dose-response curve. Response depends on concentration. So your dose and response, your dose can be considered like your X value. Your response can be considered like your Y value, if you will. So you plot. So non-competitive agonists, different binding site of agonists, not resemble chemically, a downward shift of dose-response curve. Increasing agonist concentration won't make a difference. So one more time, non-competitive agonists, you have a different binding site of agonists, not resembled chemically, you have a downward shift of the dose-response curve. Increasing agonist concentration won't make a difference in this case, or in that case. So how do we activate receptor sites? You open or close ion channels, speed up or slow down transporters, increase or decrease enzyme activity. So efficacy. What is efficacy? It is the maximum effect a drug can produce. It can be measured with a graded dose-response curve. Potency is the amount of drug needed to produce a given effect, determined by affinity of the receptor for the drug. So EC50, the dose is required for an individual to experience 50% of the maximum effect. ED50, the dose required to produce a therapeutic effect in 50% of the population. Median effective dose. So your therapeutic index, it's a ratio. It compares the blood concentration at which a drug becomes toxic and the concentration at which the drug is effective. Your LD50 over your ED50. 10 to 1 safer drug because it has a wider therapeutic index. 3 to 1 more dangerous drugs needs more attention because the therapeutic index is narrow. LD50, median lethal dose. So tolerance. What is tolerance? Reduced response to drug after prolonged use, develops gradually over a long period of time. For example, alcoholics need more alcohol on the second day to feel the same effect from the first. If it's accustomed to alcohol, so they're intense already. So let's talk about pharmacokinetic tolerance. It involves the enhanced enzymatic breakdown. It reduces the amount of drug reaching its site of action. Example, barbiturates, carbamazepine, reduce their own metabolism, so auto metabolism or auto destruction on frequent repeated use. So pharmacodynamic tolerance. So you had your pharmacokinetic tolerance. Now let's talk about pharmacodynamic tolerance. It is the tolerance caused by altered nervous system sensitivity, change in receptors. It involves the action of drug as being reduced because of downregulation of receptors, meaning that receptor expression or the amount of receptor present will be less. The receptor is not as active as before, or it involves the sensitization of receptors, meaning the receptors will not function as well. So proteins could go through PTMs or post-translational modifications, meaning that they lose, for example, a sulfide due to the drug use, losing their function. Some changes are reversible, others are not. And internalization, and that internalization of receptors, so receptor will not be available, and exhaustion of mediators, depletion of catecholamine, or epinephrine as well. So natural inherent tolerance involves the genetic makeup, makes an individual resistant or will have more response to a drug. Acquired tolerance occurs in repeated use of drug. Tolerance develops to sedative action of chlorpromazine, but not its antipsychotic action. Tolerance occurs to sedative action of phenobarbital, but not to its anti-epileptic action. So cross tolerance. Development of tolerance to pharmacologically related drugs. Example, partial tolerance between morphine and barbiturates. And then you also have complete cross-tolerance between morphine and pethidine, same drug class. So what is tachyphylaxis? What is tachyphylaxis? It's a type of tolerance that occurs rapidly within minutes or seconds when it takes a small concentration of drug to cause this. So what are some drugs that have a low or narrow therapeutic index? You have your acetaminophen, your theophylline, carbamazepine, digoxin, warfarin, lithium, phenytoin, gentamicin, vancomycin, antidepressants, bicyclic insulin. Let's talk some more. And what are your drugs with the narrow therapeutic index? Acetaminophen, theophylline, carbamazepine, digoxin, warfarin, lithium, phenytoin, gentamicin, vancomycin, antidepressants, bicyclic insulin. So drugs with a higher wide therapeutic index are your NSAIDs, your non-steroidal anti-inflammatory drugs, your benzodiazepines, most antibiotics, furosemide, and your SSRIs. Nitroglycerin can cause tolerance. As a pharmacist, you must tell the patient they need to have a 10 to 12 nitrate-free period to prevent tolerance. Nitroglycerin causes vasodilation. Let's keep going. Synergism. One drug is going to have an additive effect with another drug, increasing efficacy. Action of one drug is facilitated or increased by another drug, or when one drug is inactive alone but active when combined with another. Additive, the effect of two drugs in the same direction. Example, amlodipine. Okay, so let's keep going. So we also have, so example, do you have the additive, the effect of two drugs in the same direction? Example, amlodipine and atenolol, all antihypertensive. Amlodipine is a calcium channel blocker, and atenolol is a beta blocker. Both work to reduce hypertension and act on different places in the heart. You have glibenclamide, and metformin. Hypoglycemic glibenclamide is a sulfonylurea that increases insulin receptor sensitivity and causes secretion of insulin, acts on pancreas. Metformin acts on liver to control blood glucose level. So super additive, otherwise known as potentiation. The effect of the combination is greater than the individual effects of each component. Acetylcholine and physostigmine. Acetylcholine acts on muscle-produced effect. Physostigmine is inactive. Both are degraded by acetylcholinesterase. When acetylcholine is alone, the enzyme will break it down quickly. You have physostigmine. With it, the enzyme doesn't know which one to attack. Competition between the two, so it increases the duration of acetylcholine. Levodopa and carbidopa. Levodopa treats Parkinson's disease by converting to dopamine to prevent movement disorder. When taken orally, levodopa is converted to dopamine in the intestine, causing adverse effects like vomiting. Give it with carbidopa, which prevents the breakdown of the intestines, so it can be transported to the brain, cross the blood-brain barrier, where it can convert to dopamine to act on the basal ganglia. sulfamethoxazole / trimethoprim. Inhibits two enzymes, inflammation of tetrahydrofolic acid, which is required for bacterial cell wall synthesis. If you want to kill the bacteria, you need sulfamethoxazole to prevent the conversion of PABA to an intermediate product. And then you need trimethoprim to prevent the conversion of the intermediate product to tetrahydrofolic acid. So enalapril and hydrochlorothiazide. Enalapril, angiotensin converting inhibitor. Hydrochlorothiazide, diuretic, acts in two different places to produce the antihypertensive effect. So let's wrap this up. Drug action and enzymology. So the ES is referring to your enzyme substrate complex. The enzyme, a type of protein that speeds up a chemical reaction in a living thing. Enzymes are globular proteins, very specific. Substrate, reactant, EP, enzyme product complex, irreversible inhibition of enzymes caused by covalent bonds. Enzymes cannot be regenerated. The only way the product can be catalyzed is when new enzyme molecules are produced in the body. Reversible inhibition of enzymes. Enzymes can be freed from the complex to give the active enzyme. Ka, association constant of ligand with receptor site. Kd, association constant for the receptor. EC50, drug concentration given a response halfway between the baseline and maximum. IC50, concentration which produces 50% of the maximum possible inhibitory response, which is equal to the quantal response. Quantal response equals IC50. So affinity, the ability of a compound to bind tightly to the target. Intrinsic activity, the drug's ability to produce an effect once bound to the receptor. Potency, the amount of drug needed to produce an effect. The more potent the drug, the steeper the slope on the DRC, on the dose response curve. Efficacy. So efficacy, the potential maximum therapeutic response a drug can have. Example, furosemide eliminates more salt and water than chlorothiazide, so furosemide has a higher efficacy. Okay, so efficacy, the potential maximum therapeutic response a drug can produce. Allosteric site, or allosteria is referring to another, it's a site the drugs bind to that inserts the activity that's not the actual receptor site of the endogenous ligand. So isosteres, which is a nice word, replacement of modifications of functional groups with other groups having similar properties. So replacement or modifications of functional groups with other groups having similar properties. It tunes, make sure you remember that word, tunes the drug's metabolism, receptor fit distribution and other properties. So bioisosterism, swapping of functional groups present in the chemical compound while maintaining the desired biological activity. Corrects undesired properties. So let's wrap this up. This involves starting with the parent compound and using isosteres, which involves slightly changing the general structure to make more desirable structures. These are analogs. So isosteres of hydrogen, fluorine, isosteres of fluorine, hydroxyl, amine, so NH2 or CH3, bracket H, isosters of carbon, isosters of hydroxyl, amine, isosters of sulfur hydryl, hydroxyl, isosters of chlorine, bromine, and trifluoromethyl. So this is the end of the episode.
Grateful and humbled to be pursuing further studies as a pharmacist in training in the US. These episodes will be under the theme The Journey to NAPLEX Success. These will cover, in summative form, key points that stand out to me as I embark on my journey as a pharmacy student and chart a course in NAPLEX Success. Note the purpose of these episodes. These are not at all for advice or medical suggestions, but to provide support for pair pharmacists in training in educational and intellectually stimulating ways. These are not at all for medical advice or for medical suggestions. Please see your local state and board certified physician, PA, or NP, and pharmacist for medical advice and suggestions. The new chemist becomes a pharmacist in training, the journey to NAPLEX success. So the NAPLEX, the North American Pharmacist Licensure Examination, is a standard examination created by the National Association of Boards of Pharmacy, NABP, to help individual state boards of pharmacy assess an individual's competency and knowledge so that they may be given a license to practice. Some big abbreviations you want to keep in mind: USP, United States Pharmacopoeia 34, and Natural Formulary NF 29. So this will be episode 2A. So there will be a 2B and there will be a 2C. So this is 2A. Episode 2A. So biopharmaceutics and drug delivery systems. So some key ideas we want to keep in mind. Biopharmaceutics is a study of the relation of the physical and chemical properties of a drug to its bioavailability, pharmacokinetics, and pharmacodynamics and toxicological effects. Key terms in review: your drug product. It is the finished dosage form, example tablet capsule solution, that contains the active drug ingredient in association with non-drug, usually inactive ingredients, excipients that make up the vehicle or formulation matrix. Drug delivery system is a more complete concept, which includes the drug formulation and the dynamic interaction among the drug, its formulation matrix, its container, and the patient. Bioavailability is a measurement of the rate and extent or amount of systemic absorption of the therapeutically active drug. Pharmacokinetics is the study of the body's effect on the drug, ADME. Pharmacodynamics is the study of the drug's effect on the body. So how we're going to do this episode is going to be completely lyrical. So we're going to begin the lyrical portion right now. Biopharmaceutics and drug delivery systems. Biopharmaceutics is like a Rubik's Cube, with your 4 ideas making you drool. Bioavailability is a measurement of the rate and extent or amount of systemic absorption. Please take the right portion. The systemic absorption of the therapeutically active drug. Yeah. Biopharmaceutics includes pharmacokinetics. Your A, your D, your M, your E. The effect of the body on the drug with that A absorption, D distribution, M metabolism, and excretion. Biopharmaceutics includes pharmacodynamics with the effects of the drug on the man. We are looking at the relation between drug concentration at the site of the action, its response, which is the main caption. Woo! Then we also consider in biopharmaceutics the toxicologic effects. Lest I forget, the drug product in its formulation matrix or vehicle with the active ingredient and excipients. Lest I forget, the drug delivery with the dynamic menagerie of interactions among the drug, its formulation matrix, its container, and the patient. Continuing on with the spiel, let's drive the drug transport and absorption wheel. Across the cell membrane, the drug molecules enter the bloodstream and are transported to the tissues and organs. Let's look at some key processes in absorption. Transcellular passive, diffusion and partitioning, paracellular transport, diffusion and convection. Let me add some vocal inflections with your carrier mediated transport and the P-glycoprotein mediated efflux, which we'll get to in episode 2b. These general principles are important, you see. These general principles are important to know. These general principles are important so assimilable. Compose P. Passive diffusion. In thugs, they traverse the cell membrane easily than your ionic soluble drugs. We cannot forget the LMWs, the low molecular weight, just like the chemical thugs, across a cell membrane more easily than the high molecular weight drugs. Let's keep it going. Do you hear what I say? We will progress in pharmacy. HU, you know. Passive diffusion and partitioning within the cytoplasm, or the fluid that's interstitial. Your drugs under transport. This is not pontificial. It's simple. The simple diffusion with a great fixed law. Simple passive diffusion involves the transfer of drugs from an area of high concentration C1 to an area of low concentration C2 according to Fick's law. dq over dt equals ideally dA over H in brackets C1 minus C2, where dq over dt is the rate of drug diffusion, you see. D is the diffusion coefficient for the drug. A is the surface area of the plane across which transfer occurs. Remember your chemistry thugs. H is the thickness of the region through which diffusion occurs, and C1 minus C2 is the difference between the drug concentration in area 1 and area 2 respectively. So with the passive drug transport, welcome to my conceptual court. It involves successive partitioning of a solute between aqueous and lipid phases, as well as diffusion within respective phases. Modifying. Fixed law, please. Let's applaud. I'm kidding, but we do this to accommodate partitioning of drug. dq over dt equals d times a times k over h in brackets C1 minus C2, where hold it, the rate of drug diffusion dq over dt now reflects its dependence on k, the oil to water partition coefficient of the drug, as well as on A, and in brackets C1 minus C2. Rum pa tum tum. Ionization of a weak electrolyte. You know I always wanted to be an acolyte, a thurifer, a catechist, or a trumpeter, you see, but today we're talking about my good friend, not the trumpeter, but le chatelier, in the ionization. So ionization is affected by pH of the medium in which the drug is dissolved, as well as by the pKa. Remember, non-ionized are like the chemical thugs, more lipid soluble, the diffusive plug, if you will. They are more lipid soluble than the ionized, and it partitions more readily. Hopefully by now you realize. Rumpa tum tum, let's have a drum roll. Here, little beggar boy. Oh, that's 4. The periodic table. Let's talk about the transport process that's not a fable. The active transport of the drug, with it moving across a concentration gradient, requiring energy, selective potentially, saturation possibility, and competitive it can be. Yet we must look across the hall and see that facilitated diffusion is on the carrier-mediated transport system walls. Facilitated diffusion occurs across a concentration gradient and does not require energy. Obrigada, e você? Como você está? Tudo bem? Tudo bem? Tudo. Wow, fala pequeño português. So let's talk in English, por favor. S'il vous plaît. With that paracellular transport, drug transport across tight, narrow junctions between cells or trans-endothelial channels. No, I'm not talking about fire stick, but let me give you a conceptual trick. Paracellular transport involves both diffusion and convective or bulk flow of water and the accompanying water-soluble drugs through the channels. That can be a hint. Now let's look at the vesicles. Newly minted idea in this lyrical scheme. Vesicular transport is the process of engulfing particles or dissolved materials by a cell. Engulfment. Pino, we're drinking. Phago, we're eating. Pinocytosis, engulfment of small solute or fluid volumes. Phagocytosis is the engulfment of larger particles, your macromolecules, generally by macrophages. Endocytosis and exocytosis are the movement of macromolecules into and out of the cell. Biopharmaceutics and drug delivery systems. So we've reached the end of this lyrical scheme. You see, but we'll pick back up conceptually in episode 2B. Okay, so grateful and humbled to be pursuing further studies as a pharmacist in the US. These episodes again will be under the theme The Journey to NAPLEX Success. These will cover in summative form key points that stand out to me as I embark on my journey as a pharmacy student and chart a course to NAPLEX Success. Note, the purpose of these episodes not at all for advice or medical suggestions, but to provide support for peer pharmacists in training in educational and intellectually stimulating ways. Not at all for medical advice or medical suggestions. Please see your local state and board certified physician, PA or NP, and pharmacist for medical advice and suggestions. The newcomer becomes a pharmacist in training, the journey to NAPLEX Success. The North American Pharmacist Licensure Examination, NAPLEX, is a standard examination created by the National Association of Boards of Pharmacy, NABP, to help individual state boards of pharmacy assess an individual's competency and knowledge so that they may be given a license to practice. So this is an important exam. So big abbreviations we want to keep in mind as we conclude. USP 34, United States Pharmacopoeia 34, and NF Natural Formulary 29. So this is the end of the episode. Thanks for listening. First 100, first 100, 1, 2, 1, 2. First 100, first 100, first 100K. Let's rhyme while we can. This is a learning trip with the brand, and the generic. Very fast, let's go. Let's look at the drug class A. First 100A, first 100A, first 100K. First the brand, then the generic. Okay, let's go fast and we'll race to the drug class. Keflex, cephalexin, the antibiotic class it is in. Glucophage, metformin, hydrogen chloride. Diabetes is the drug class it is inside. Lipitor, atorvastatin. Cholesterol is a DC-10. Omnicef, cefdinir. Antibiotic drug class. Yes, sir. Nexium, esomeprazole. Anti-ulcer class. Yeah, this has a benzodiazole. Tenormin, atenolol, all. Blood pressure drug class with that functional group. Yeah, alcohol. Prozac, yeah, fluoxetine, the antidepressant, yeah, DC is seen. Ultram, oh yeah, tramadol, analgesic, that DC is called. Prevacid, lansoprazole, anti-ulcer, it's a member of the benzimidazole. Bactrim, sulfamethoxazole, trimethoprim. The antibiotic is a DC, it's in. Prilosec, yeah, that omeprazole. Anti-ulcer DC, come on, let's fold. First 100A, first 100A, first 100K. Percocet, oxycodone APAP. It's in the analgesic DC, you see. Plavix, clopidogrel bisulfate. Heart disease DC, can you tell? Xalatin, oh yeah, latanoprost, it's in the glaucoma DC. Okay, let's toast. First 100A, first 100A, first 100K. Ativan, yeah, lorazepam, anti-anxiety DC. Yes sir, yes ma'am. Valium, diazepam, anti-anxiety. Let's go swimming since I swam in high school. First 100A, first 100A, first 100K. Humalog, insulin less pro. It's in the diabetes DC, you know. Deseril, trazodone hydrogen chloride. The antidepressant DC, it's inside. First 100A, first 100A, first 100K. Ortho tricycline, low. Norgestimate, or EE. Contraceptive, yo. Premarin, conjugated estrogen. Hormone replacement DC, it is in. Osifex, rabeprazole. Anti-ulcer, wow, you are on a roll. First 100A, first 100A, first 100K. Methotrexate, amethopterin, the anti-metabolite DC, it's in. Estrace, the estradiol, hormone replacement, the DC is called. Cleocin, clindamycin, the antibiotic class, it is in. Combivent, ipratropium, or albuterol, COPD drug class is called. Diovan, valsartan, the blood pressure DC, it is in. Wow, yes we can. Yes we can. First 100A, first 100A, first 100K. Nikon, mestranol, or norethindrone, contraceptive DC, it is known. Avandia, rosiglitazone, diabetes DC, it is known. Amaryl, glimepiride, diabetes DC, it is inside. Guafanex, PSC, guafanesin, or PSC, nasal congestion or expectorant, you see. Cymbalta, dual oxetine, hydrogen chloride, antidepressant, it is inside. Diflucan, fluconazole, antifungal is the DC, I'm told. Flomax, tamsulosin, hydrogen chloride. Enlarged prostate is the DC, it's inside. Octonel, risedronate sodium, anti-osteoporosis is the DC. Celebrex, celecoxib, anti-inflammatory. So let's have it. First 100A, first 100A, first 100K. Macrodantin, nitrofurantoin, antibiotic is a DC coin. Spiriva, tiotropium bromide. Asthma is the DC, it's inside. Glycolax, polyethylene glycol. Laxative is a DC. Drum roll. First 100A, first 100A, first 100K. Clonopin, clonazepam. Anti-anxiety, yes sir, yes ma'am. Tylenol, acetaminophen, or codeine. Analgesic DC is on the scene. Sildenafil, Viagra, erectile dysfunction. Voila, Zetia, ezetimibe. Cholesterol is the DC, it's inside. Medrol, methylprednisolone. Anti-inflammatory is its DC zone. Norvax, amlodipine mesylate. Blood pressure DC, that is great. Cipro, ciprofloxacin, antibiotic DC, it's in. Let's try that back. Ciprofloxacin, antibiotic DC, it is in. Destril, lisinopril, blood pressure DC. Okay, now chill. First 100A, first 100A, first 100K. Trinessa, norgestimate or EE. Contraceptive DC, that is great. Synthroid or Levoxil, levothyroxine, thyroid replacement. Sidebar, my brothers will. What? Let's get back. First 100A, first 100A, first 100K. Allegra, fexofenadine, hydrogen chloride. Allergy is DC on the scene. DC, for all those listening, is how we refer to the drug class it's in. First 100A, first 100A, first 100K. Proventil or Proel-Ventolin, albuterol sulfate, asthma DC, it's in. Chlorcon, potassium chloride, potassium replacement DC, it's inside. First 100A, first 100A, first 100K. Phenergan, promethazine hydrogen chloride, cough suppressant DC, it is inside. Penvic, penicillin, antibiotic class, it is in. Levaquin, levofloxacin, antibiotic class, it is in. Antibiotic. Hydrodiaryl, hydrochlorothiazide, diuretic DC, it is inside. Folbine, folic acid, supplement DC. Wow, this list is massive. First 100A, first 100A, first 100K. Protonix, pantoprazole, anti-ulcer DC is what I'm told. Zocor, simvastatin, cholesterol DC is what it's in. Flexeril, cyclobenzaprine, muscle relaxer DC, this is a farm dream. Zyrtec, cetirizine, allergy DC is a class on the scene. Fosamax, alendronate sodium, osteoporosis DC, this is intellectual matrimonium. First 100A, first 100A, first 100K. Lantus, insulin glargine, diabetes DC is on the scene. Lexapro, escitalopram, antidepressant DC, yes sir, yes ma'am. Xanax, alprazolam, anti-anxiety. Let's camcord this. Whoa! First 100A, first 100K. Singular, Montelukast sodium. Asthma is a DC, so let's go. First 100A, first 100K, first 100A. Neurotin, gabapentin, anti-neurotic DC, it's in. Lasix, furosemide, diuretic DC, it's inside. Amoxicillin, antibiotic DC, it's in. Antibiotic. First 100A, first 100A, first 100K, Flonase, fluticasone, propionate, allergies DC. That is great. Antidepressant. Whoa, I could use a break. First 100A, first 100A, first 100K, Vicodin, hydrocodone, OIPAP, analgesic, DCIC. Let's go back again. Wellbutrin or Zimban, bupropion, hydrogen chloride, antidepressant. I could use a trip inside to the ice cream store. First 100A, first 100A, first 100K. Vicodin, hydrocodone, OIPAP, analgesic, DCIC. Zithromax, azithromycin, antibiotic DC, it's in. Motrin, ibuprofen, anti-inflammatory DC, it's in. First 100A, first 100A, first 100K. Effexor, venlafaxine, hydrogen chloride, antidepressant DC, it's inside. Deltazone, prednisone, anti-inflammatory DC is in the zone. Zoloft, sertraline, hydrogen chloride, antidepressant DC, it's inside. Advair, fluticasone, propionate, osameterol, asthma DC, that's great. Let's call it a draw. First 100A, first 100A, first 100K. Nasonex, mometazone furoate, allergies, DC, that's great. Tricor, fenofibrate, cholesterol DC, to that class, don't be late. Celex, citalopram, antidepressant DC, yes sir, yes ma'am. Viterin, ezetimibe, or simvastatin, cholesterol DC is what it's in. Yasmin, dosperenone, or EE, it's a contraceptive DC. You see DC in this rap, let me remind you, stands for that drug class, so don't fall behind the stand. First 100A, first 100A, first 100K. Fibromycin, doxycycline, antibiotic DC, that's fine. Fibromycin, doxycycline, antibiotic DC, that's fine. Paxil, paroxetine, antidepressant DC on the scene. Crestor, rosuvastatin, cholesterol DC, it is in. Diazide, or Maxide, HCTZ, triamterene, that diuretic DC is on the scene. Detrol, tolterodine, tatrate, that overactive bladder DC, so don't be late to the test. Whoa! First 100A, first 100A, first 100K. Mevacor, lovastatin, cholesterol DC is what it's in. Tusionex, chlorpheniramine, or hydrocodone, that cough suppressant DC is that zone it's in. First 100A, first 100A. Elavil, amitriptyline, antidepressant drug class is on the scene. Aldactone, spironolactone, diuretic DC is the zone. Minocycline, antibiotic DC, so pristine. First 100A, first 100A, first 100K. Evista, raloxifene, osteoporosis DC, it's in. Lotril, amlodipine, or benzapril, blood pressure DC, so just chill. Minocycline, antibiotic DC, so pristine. First 100A, first 100K, first 100A. first 100A, first 100A, first 100A, first 100A, first 100A, first 100A. Mobic, meloxicam, anti-inflammatory DC, yes ma'am. Ambien, zolpidem, tartrate, a DC. So say it again now. Ambien, zolpidem, tartrate, that sedative DC. So say first 100A, first 100A, first 100K. Xyloprim, allopurinol, that anti-gout DC. Come on, let's go on that. Crawl. First 100A, first 100A, first 100K. Adderall, dextroamphetamine, an amphetamine. CNS stimulant is on the scene. Adderall, dextroamphetamine, and amphetamine. CNS stimulant is on the scene. Cialis, tadalafil, erectile dysfunction DC. Wow, chill. First 100A, first 100A, first 100K. Okay, so this will be an addendum to the episode in which we discuss some common abbreviations outlined in pharmacy. Some of these are in Latin, many of these are in Latin. So AA dot, ana, of each, AD, up to make. So just draw back, AA dot, ana, which means of each, AD, add, which means up to or to make, DISP dot, dispensator, dispense means to dispense, DIV dot, divator, divide, D dot T dot D, denter talis doses, which means give us such doses, FT fiat, which means to make, capital M dot mise, which means to mix, N, capital N, O dot numero, which means number, non, space, rep, REP dot, or NR, which both are capitalized, means non-repetitor, and that means to not repeat. QS, quantum sufficient, a sufficient quantity. QSAD, Q dot S dot AD, quantum sufficient add, a sufficient quantity to make. SIG dot signa, which means to write, in brackets directions on label. So some common abbreviations, you have BSA, body surface area, cm raised to the 3, cubic centimeter or milliliter. F or FL, fluid. Let's go through some more. G is gram, GAL is gallon, GTT, gutter, which means drop, I.U. or IU, international units, LB, libra, which means pound, kg, kilogram, L, liter, M to the second, or capital M to the second, square meter, MCG, microgram, MEQ, milliequivalent, mg, milligram, mg over kg, milligrams of drug per kilogram of body weight, mg over m squared, milligrams of drug per square meter of body surface area, m, capital IU or milli, IU, thousandth of an international unit, capital M, capital I, capital U, million international units, ml, milliliter, ml per h, milliliters of drug administered per hour as through intravenous administration. M, capital OSM, or M, capital OSMOL. So M, capital O, lowercase s, lowercase m, or M, capital O, lowercase s, lowercase m, OL, milliosmoles. So OZ dot, ounce, PT pint, QT quart, SS or SS with a line over both S's means 1/2. Semisem. TBSP dot tablespoonful. TSP dot teaspoonful. Admin administer. AM ante meridium. Morning. AQ dot aqua water die twice a day. C or C with a line over it. Come, which means with. D in bracket or die, which means day. DIL dot dilutus dilute. Et and H dot or HR dot aura, which means hour. HS aura somni at bedtime. IC intercibos between meals. MIN dot minutum minute. M and N morning and night. N and V, both N and V are capitalized. Nausea and vomiting. NOCT dot nocte night. NPO non per os, nothing by mouth. PC post cibos after meals. PM post meridium, afternoon or evening. PO per os by mouth or orally. PRN pro re nata as needed. Q quaque every. Q capital AM every morning. Q4H or Q8H etc. every. Number in brackets hours. QID quarter in die 4 times a day. QID quarter in die 4 times a day. Rep dot repetitor repeat. S sine without. SID semel in die once a day. SOS C opposite if there is need as needed. SOS C opposite if there is need or as needed. Stat stamnen immediately. TID tur and die 3 times a day. Ut dictum as directed. WK dot week. So APAP acetaminophen. So a PAP acetaminophen. ASA aspirin. AZT zidovudine. EES erythromycin ethyl succinate. HC hydrocortisone. HCTZ hydrochlorothiazide. MTX methotrexate, NSAID, non-steroidal anti-inflammatory drug. So MTX, methotrexate, NSAID, non-steroidal anti-inflammatory drug. NTG, nitroglycerin. So clinical abbreviations, you have AFib, atrial fibrillation, ADR, adverse drug reaction. You also have BM, bowel movement. All of these are capitalized. BP, blood pressure. BS, blood sugar. CAD, coronary artery disease. CHD, coronary heart disease. CHF, congestive heart failure. COPD, chronic obstructive pulmonary disease. Okay, COPD, chronic obstructive pulmonary disease. GERD, gastrointestinal reflux disease. CRF, chronic renal failure. CV, cardiovascular. ENT, air, nose, and throat. GI, gastrointestinal. GFR, glomerular filtration rate. GU, genitourinary. HA, headache. HBP, heart rate. HR, high blood pressure. HRT, hormone replacement therapy. HT or HTN, hypertension. HT or HTN, hypertension. IOP, intraocular pressure. MI, myocardial ischemia / infarction. So MI, myocardial ischemia / infarction. OA, osteoarthritis. PT, patient. QL, quality of life. So P is capitalized, T is lowercase. Patient. QL, quality of life. RA, rheumatoid arthritis. SOB, shortness of breath. And that means dextrose 5% in lactated ringers. D5NS, dextrose 5% in normal saline, in brackets 0.9% sodium chloride. D5W, dextrose 5% in water. D10W, dextrose 10% in water. ELIX dot, elixir, INJ dot, so INJ dot, injection. NS, normal saline. Half NS, half strength normal saline. Oint or UNGT, unct, or that means, so unct, UNGT means unguentum, and that means ointment. So UNGT dot stands for unguentum, which means ointment. PULV dot pelvis, L dot solutio, solution. SUPP dot suppositorium, suppository. SUSP dot suspension, SUSP dot suspension. SYR dot syrupus, syrup. CAB dot tabletta, tablet. So routes / location of administration. A.D. aureus dextro, right ear. A.S. aureus sinistro, left ear. A.U. aureus utro, each ear, or both. Capital CIVI, continuous, in brackets 24 hours, intravenous infusion. ID, intradermal. INJ, injection. IM, intramuscular. IT, intrathecal. IV, intravenous. IVB, intravenous bolus. IV drip, intravenous infusion. IVP, intravenous push. IVPB, intravenous piggyback. NGT, nasogastric tube. NGT, nasogastric tube. O.D. oculodextro, right eye. O.S. oculosinistro, left eye. O.U. oculoutro, each eye. So both P.O. or PO, per os, by mouth. REC. Or prorecto, rectal or rectum. So REC. Or prorecto, which means rectal or rectum. SL, both S and L are capitalized. Sublingual. SUBQ or SC, subcutaneously. TOP. Of the addendum. Welcome to the New Chemist podcast.
Bienvenidos al podcast del nuevo químico.
Καλώς ήρθατε στο podcast του New Chemist. Welkom bij de podcast van The New Chemist. Bienvenue sur le podcast du nouveau chimiste.
Bem-vindo ao podcast do novo químico.
Welcome to the New Chemist podcast. Work hard. Be value driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here, rooting and cheering for you. Don't give up.
Travaillez dur. Soyez axé sur la valeur. Tu peux le faire. Vous pouvez grandir et l'apprendre. Vous pouvez être la différence dont vous et votre communauté avez besoin. N'abandonnez pas. Nous sommes ici pour vous encourager et vous encourager. N'abandonnez pas.
Trabalhar duro. Seja orientado por valores. Você consegue. Você pode crescer e aprender. Você pode ser a diferença que você e sua comunidade precisam. Não desista. Estamos aqui torcendo e torcendo por você. Não desista.
Δούλεψε σκληρά. Να οδηγείτε στην αξία. Μπορείς να το κάνεις. Μπορείτε να μεγαλώσετε και να το μάθετε. Μπορείτε να είστε η διαφορά που χρειάζεστε εσείς και η κοινότητά σας. Μην τα παρατάς. Είμαστε εδώ για να σας ζητοκραυγάσουμε. Μην τα παρατάς.
Trabaja duro. Sea impulsado por el valor. Puedes hacerlo. Puedes crecer y aprenderlo. Usted puede ser la diferencia que usted y su comunidad necesitan. No te rindas, estamos aquí animándote y animándote. No te rindas.
Werk hard. Wees waardegedreven. Je kunt het. Je kunt groeien en leren. U kunt het verschil zijn dat u en uw gemeenschap nodig hebben. Geef niet op. We zijn hier om voor je te roten en te juichen. Geef niet op.
Work hard. Be value driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here rooting and cheering for you. Don't give up. Thanks for listening. We're glad you were able to tune into this podcast. Once again, this is The New Chemist, where we discuss chemistry, which simply put is the science of change, as well as the other sciences, careers, community, research, and COVID-19. Thanks again for listening. Note, the views on this podcast represent those of my guests and I. You are very important, especially to us here at the New Chemist podcasting group. You listening in is significant.
Vous êtes très important, surtout pour nous ici au New Chemist Podcasting Group. Votre écoute est significative.
Usted es muy importante, especialmente para nosotros aquí en The New Chemist Podcasting Group. Usted escuchando, es significativo.
Você é muito importante. Especialmente para nós do The New Chemist Podcasting Group. Você ouvindo, é significativo.
Είστε πολύ σημαντικοί, ειδικά για εμάς εδώ στο The New Chemist Podcasting Group. Το να ακούς είναι σημαντικό.
Sie sind sehr wichtig, besonders für uns hier bei The New Chemist Podcasting Group. Es ist wichtig, dass du zuhörst.
Je bent erg belangrijk, vooral voor ons hier bij The New Chemist Podcasting Group. Dat je meeluistert, is veelbetekenend.
You are very important, especially to us here at the New Chemist Podcasting Group. You listening in is significant.